Good morning and welcome back to the PTAC session after the short break, and I am going to immediately hand it off to my co-chair, Lauren.
Thank you so much, Angelo. Welcome back. Walter and the PCDT shared our starting point for this public meeting and some of the questions we want to explore. At this time, I'm excited to welcome our first panel discussion. In this session, we have invited 4 esteemed experts to discuss how they provide patient-centered care for patients with complex chronic conditions or serious illnesses in total cost of care models. After each panelist offers a brief overview of their work, I will facilitate the discussion by asking each panelist questions on the topic. The full biographies of our panelists can be found online along with other materials for today's meeting. I'll briefly introduce each of our guests and give them a few minutes each to introduce themselves. After all 4 introductions, we'll have plenty of time to ask questions and engage in what we hope will be a robust discussion today. First, we have Mr. Erik Johnson, who is the Senior Vice President of Value-Based Care at Optum Advisory. Erik, welcome. Please go ahead. And we can't hear you, Erik. You need to unmute. Thank you.
There we go. Thanks, Lauren. It's a privilege and an honor to be addressing the panel today. Appreciate the invitation, and hopefully this will be a good setup for the rest of my panelists. So it's important to note up front that I come from the Optum Advisory Services branch of Optum. I know Optum is a vast enterprise. I am in the consulting arm of Optum Insight. I run the value-based care and population health practice here. Been doing that for the better part of 9 years, and I've been a healthcare consultant probably for longer than I care to admit, about 28 years now at this point. Optum Advisory is a consultancy of about 2,000 consultants who are focused exclusively on healthcare across the gamut. My particular practice focuses on providers who are looking to move closer to what I would call first dollar premium risk. It doesn't necessarily mean that they're going to get all the way there, but they are looking to engage in risk-based contracting arrangements and develop, deploy, and implement the population health programs that they need in order to manage the attributed or enrolled populations that they're responsible for. Our goal really is to move decision-making as close as possible to the point of care and to eliminate as much abrasion between the patient and the provider and the member and their benefit as possible. And I think those are 2 very different vectors that we need to keep in mind as we think about delegated risk arrangements, particularly with respect to complex and polychronic populations. So with that in mind, if we could just go to the next slide, Lauren, we'll lay out a little bit of how we think through, at a very high level, how we sort of organize this work. The first element that we always strive to accomplish is a consistent risk stratification of the population pool. I should probably say it's also a persistent risk stratification of that population, particularly though that population that represents actuarial risk. It's changing. There's churn in who is most at risk at any given time. So we like to run that type of stratification at least monthly for our clients and the populations that they serve. What we have found is that, particularly with complex populations, they go from hidden risk to rising risk to risk relatively unpredictably. And we want to make sure that we are tracking those populations and changing workflows accordingly as we run that stratification. So the first is to understand really who are we focused on and who should we be investing the most interventions in. The second is to organize the care team around those populations. We really focus on promoting and designing team-based care that incorporates the increasing insights that we have into social determinants of health and health-related social needs, documenting those variables in a patient's record and documenting it with the patient's family. At the very end of the previous session, I heard I think Dr. Lynn talk about the importance that families have really placed on palliative and hospice care and how glad they are that they were able to avail themselves of that. I think that's an incredibly important point, but I also think we are increasingly availing ourselves of family and caregivers for complex populations that are not in a palliative or hospice state of affairs. And then finally, once that care team is organized, what we really try to do is to bridge the gap between providers and payers for that identified population and remove some of the barriers to access that a lot of patients are facing in the marketplace today. Again, we particularly see this with the sickest populations. The barriers to access to care and the barriers of access to their benefits has become a real problem that we will talk about a little bit when we get into the Q&A. We have some case examples and some ideas that we found to be pretty successful in managing that type of smoothing of the care continuum. So that's kind of how we organize our risks: stratify, organize, and remove barriers. That's generally the three guiding lights of our approach to managing these populations. I will say that we do focus quite a bit on the complex and polychronic, largely because that's where the money is. And I hate to sound like the cold, black-hearted, dead inside consultant that I am, but that is, if you are taking risk on a population, that is where there is money to be made. That is where there is utilization to be eliminated, and that is where there are quality opportunities to be obtained. So that's where we really focus. We also focus quite a bit on the annual wellness visits and making sure that the non-chronic population gets access to care, but in a delegated risk environment, we're really focusing on this particular population. So as a tee-up, that's kind of how we think about it. I will hand this over to my fellow panelist, Dr. Feifer, to get into some actual on-the-ground care models.
Thank you so much, Erik. And next we have Dr. Richard Feifer, who's the Chief Medical Officer at Innovage. Rich, please go ahead.
Thanks. And it's pronounced Innovage because we have a very older population. In fact, to Erik's point, it's where the money is. It's where the clinical opportunity is. So again, thank you also for having me join this group today. I am the Chief Medical Officer at Innovage, where I lead all clinical services, population health analytics, and network management. And before that, I was the CMO at Genesis Healthcare, the largest operator of skilled nursing homes, skilled nursing facilities and nursing homes, where we started up the first long-term care ACO through the Medicare Shared Savings Program. So we can talk about that if you want later. But PACE, Innovage, is the largest provider of PACE programs in the country, which is sometimes called Life in some states. PACE has been around for about 30 years, but it's one of the least recognized and yet most mature value-based payment models. PACE is for the frailest of the frail, mostly elderly. It provides a concierge-like integrated care model where approximately 30% of our population's costs are provided through care that we deliver versus care that is delivered outside of us through our network or through acute care and post-acute environments. Our participants, which is what we call our patients, see our primary care providers on a very frequent basis, and our PCPs carry very, very small panels. They only see 3 to 7 people a day, but are very busy with population health and other activities throughout the day as well. We receive dual capitation from Medicare and Medicaid. And so back to Erik's point, where the money is, our annual capitation combined is roughly $100,000. That's because we're responsible for everything that happens. We're responsible for all the traditional Medicare A, B, or C costs. We're responsible for residential costs if people need them, if they need to move to assisted living or long-term care, and obviously acute care. That's all on us. So we have a very, very strong incentive to keep people independent as long as possible. So Innovage operates 20 centers in 6 states and nearly 7,000 participants. If we could go to the next slide. Some highlights for us around high-value care delivery approaches, and I hope we get to talk about them more during the Q&A, is that PACE programs focus a lot on interprofessional team-based care. That is the legislated model, and it works very well. All care decisions are made by a team that meets every single day to discuss their population. There's an enormous focus on goals of care and advanced care planning as there needs to be for this population. We integrate end-of-life care. We integrate palliative care as much as we can because it's interwoven in care delivery versus something that should be delivered by somebody else. We focus on holistic care versus disease-centric care. So as we think about disease management and we think about quality metrics, it's very important to have that perspective because one can very quickly go off the rails in terms of population management if we get too disease-focused for this population. For us, everything's about ER diversion because our population, when they roll into an ER, they all look like someone who could be admitted, but in fact, with the right wraparound care and the right ambulatory services, many of them do not need to be. We focus more and more on creating high performance networks of assisted living and nursing facilities and skilled nursing facilities versus what would be in any willing provider network, because these are our partners in care delivery. And we have every incentive to address social determinants of health because there are, frankly, no limits to what we can cover out of our capitation. Some watching out for polypharmacy, which sometimes arises from too much of a disease focus care. Watch out for trying to create too much cancer screening that is not appropriate for the life expectancy of this population. And watch out for Part D pharmacy coverage, which is the one exception to the holistic, fully integrated capitated model for PACE, because in fact, Part D has some risk sharing in risk corridors, but for the most part is a pass-through cost. So that creates some interesting dynamics. All else is out of capitation. Part D is carved out and managed separately. We do manage Part D, but a lot of that is pass-through. But with that, I'll turn it over to my colleague and we'll come back to Q&A later. Thank you.
Thank you so much, Rich. And next we have Dr. Kristofer Smith, who is the Chief Medical Officer of Landmark Health. Welcome, Chris. Please go ahead.
Thank you. Good morning. And Rich, thanks for your comments. I agree wholeheartedly with them, and that PACE is a great program that we need to have more of. So let me tell you a little bit about my background. I'm currently both the Chief Medical Officer for Landmark, but I'm also the Chief Medical Officer for Optum at Home, which is an umbrella organization within Optum Health that includes Landmark, as well as a legacy Prospero company and our duals program. So currently this Optum at Home program is at risk for about 1.15 dually eligible special needs plans patients and over 600,000 Medicare Advantage group and individual lives. We meet the needs of patients across this continuum through a variety of in-home care models. So we provide home-based medical care to the most complex patients within those populations. We have about 150,000 patients who are engaged in that program. And then we provide a variety of care management services depending upon the level of complexity for patients. The scale is rather large, 35 states, over 3,000 clinicians, which has its own challenges around how do you know that the program you have in your PowerPoint presentation is the actual clinical care that's being provided at the point of care with patients and families. And hopefully we can talk a little bit about that. Personally, I bring the experience of having been in the population health space for the last 16 years. There's almost no program that I haven't had the challenge of trying to stand up, whether that's home-based medical care programs, bundled payment programs, programs for high-risk community dwelling Medicaid patients, payment integrity, affordability. And so a lot of the comments that you'll hear from me today are steeped in the real practical challenges of moving from a concept of, yes, high cost, highly complex patients need better services, to working through the day-to-day challenges of making sure that we are attending to their needs in such a way that they don't need to go to the emergency room. And so with that, if you could turn to the next slide, a couple of key learnings. I tried to not repeat Rich's key learnings since I think we have some very similar experiences, but I think that, and we'll get into this, and we already heard earlier that not all complex patients are persistently high cost. I think you'll hear from our comments about different subpopulations that we think have more durable high costs. We also, in the work that I've done over the years, these patients have multiple chronic illnesses. Disease management programs tend not to be particularly effective. But in order to be effective, one of the things that conceptually we like to talk about a lot in the programs that we build is you have to have sort of a reactive component to your program and a proactive component to your program. The reactive is, patients are going to think of you, family members are going to think of you when their loved one deteriorates. Like, you have to be ready to provide a meaningful response to those patients in a manner that is timely. And timely is important to the patient, not based on what the program can do. And then proactive, this is where, we need the proper care plans for patients, proper evidence-based medicine for patients so that they have fewer of those exacerbations. And so we think, broadly speaking, about having a reactive part of our model and a proactive part of our model. And then finally, some key learnings over the last several years is that the financial reconciliation in this space continues to be fraught. And without an ability to understand how you're performing in year and how that will lead to positive or negative financial reconciliations, as well as how do we accommodate for changing baselines as these programs first get set up and then continue to grow and move forward. So if we don't figure that out in a more predictable way, we'll continue to have programs that initially seem to be quite successful, but then stumble in the out years of these programs. Next slide. And then finally, just a few things to watch out for. I like to call it the tyranny of the easy to implement. That's the telephonic case management program that doesn't work, hasn't been shown to work yet. It's really easy to operationalize compared to something as complex as PACE. One of the things that we've been seeing is the trap of top of license. As you build interdisciplinary teams, one of the big challenges is everybody wants to only do top of license activity. And the next thing you know, you've hired a new role type, a new role type, a new role type. They all have overlapping responsibilities, and you diffuse who's responsible for the total outcomes for patients. And so I think our interdisciplinary teams need to stay tight and not be super diffuse. And then the siren song of efficiency, this is where, isn't it better to have a nurse instead of a doctor? Isn't it better to have a community health worker instead of a nurse? And slowly you move down the efficiency chain and you've lost some of the real recipe and the adherence to the evidence about what we know works for complex populations. Scaling too fast and saying culture is important, but not living it in decision-making, I think is another area where, particularly as we have these disruptor organizations who have interesting early results, and then they decide they're going to scale very quickly, can't maintain culture, and are focused more on scaling for a turn or an exit as opposed to maintaining the integrity of the model that got you there in the first place. So thank you for having me, and I'll turn it over to Marshall.
Yeah, thanks, Chris. And good morning, everyone. I'm Marshall Chin. I'm a general internist and a health services researcher at the University of Chicago. Clinically, I do mostly outpatient work, and I'm in the middle of an inpatient general medicine attending block right now. Just came back from rounds where most of our patients are of the topic today of complex patients with multiple chronic conditions and serious illness. My other two roles, which are relevant for today, are that for the past 18 years, I've directed or co-directed one of the Robert Wood Johnson Foundation's major health equity programs. The current iteration is called Advancing Health Equity, Leading Care, Payment, and Systems Transformation. We're working with 12 teams of diverse stakeholders. A team consists of a state Medicaid agency, a Medicaid managed care organization, at least 2 frontline healthcare delivery organizations, and community-based organizations. And each of these state teams is trying to align payment and care transformation to address medical and social needs, to advance health equity, all within an anti-racist culture of equity. For the past 3 years, I've co-chaired for the CMS Healthcare Payment Learning and Action Network, their Health Equity Advisory Team. The so-called Learning and Action Network is a multi-stakeholder group of 200, 300 different stakeholders. And the Health Equity Advisory Team, we have a model of change, which has 3 main levers: care delivery organization, payment, and performance metrics. Next slide. So I think you're going to find a lot of similarities across all 4 of us on our panel regarding our overall take on the field. And what I'm going to do over the next hour, I'll try to take the equity lens. So with each of the different issues and questions, really try to think about it through an equity lens. And so when you do the literature review on this topic for what is an equitable intervention, it's basically what everyone else has mentioned so far. It devolves down to holistically addressing medical and social needs, effective communication and strong relationship with patients, close follow-up and monitoring of patients, team-based care, cultural tailoring, heavy involvement of families and communities. So it's not rocket science. So it's really, in some ways, an implementation issue as opposed to really a conceptual issue. For equity, it doesn't work unless we intentionally design the different interventions to advance health equity. And then the third bullet is an important one, that it's not payment reform for payment reform's sake, but the payment and the economy metrics need to support and incentivize the intended care transformations. And these need to align with social return on investment. And this is a big problem because right now the system is not aligned to incentivize social return on investment. This is actually the major thing we're working on with the Health Equity Advisory Team of the CMS group over the next year, this idea of social return on investment and payment in performance metrics. And then also these transformations need to align with interventions that address the spectrum, and the spectrum of healthcare equity interventions, health-related social needs, there's a lot of attention on that right now, and then also structural social drivers of health. I think like right now, there's just too much magic carpet thinking in our field. Basically, you do a 30,000-foot intervention, a policy intervention, a payment intervention, and then you magically think it's going to then connect the dots along on these different components of this third bullet. But you have to connect the dots, and we're not really doing that very often. For example, we got the discussion questions for our session maybe on Friday, and I think they're the questions that will generate a lot of good discussion. But in some ways, I think they're not really the right questions. A lot of questions assume that there's sort of a magic bullet solution. That what are these model programs? The reality is that everything is context dependent, and it needs to be contextualized context. There's also sort of a subtext in many questions of like, what are the patient characteristics? What are the provider characteristics? Which can devolve down to a blame the victim approach as to a heavy emphasis upon thinking about what are the structural systemic problems that are driving the issue here. And I would say that one of the problems we have right now is that we have largely skirted addressing the underlying structural systems. And what an equity person would say is that there's a lot of like the current systems, which is rooted in structural racism and classicism, like two-tiered systems and all. And so and then a lot of the current solutions tend to build upon the chassis of the traditional system and the chassis of fee-for-service and all. So we tend to undervalue primary care and prevention. We undervalue care coordination. We undervalue good communication and trust. We undervalue addressing social needs. And then, as I think like the last person before our panel today talked about, we undervalue integrating mental health and substance use systems. And so a lot of it tends to be incremental and not really addressing the fundamental problems. We tend to have a short time span in terms of more of a medium term of addressing the longer term issues. So thank you. And I look forward to particularly adding the equity lens on a lot of the issues today.
Thank you so much, Marshall. And I can tell all four of you very interesting perspectives. And I want to encourage you to take these questions to the next level with what you'd like to discuss, because I think you've all brought up really important points. So I'll get us started with a few basic questions that you were sent ahead, and the the PTAC panel group is also going to be asking questions. So first of all, the first question is, what are the most important clinical characteristics and challenges associated with treating high-cost patients with complex chronic conditions or serious illnesses in total cost of care models? And Erik, would you please start?
Be delighted to. Well, the biggest challenge is knowing who they are. That's why we spend a little bit of time at the top of my comments talking about risk stratification and persistent stratification of the population to know who is starting to move into the key element of the bullseye. That can be difficult to do if you don't have a good attribution model. So you can actually track patients against primary care doc. But if you do have a good attribution model in place, and I think CMS has given us a lot of good attribution models over the last 12 years, it's not that hard to know who needs care. The next question, I think, the really big challenge is what kind of care do they need, and in getting to the root cause of what their needs actually are. And I think a lot of that, building on the last set of comments, is understanding the context in which they are trying to get care. What is their social situation like? What is their access like? So answering the question, why aren't these patients getting timely and coordinated care, often means gaining an understanding of that patient's circumstances. And once you even have that understanding doesn't necessarily get reflected in an EHR very well. There are all sorts of technical challenges in addressing these populations, and interoperability remains a big issue 15 years after the stimulus bill. But I think beyond that, just being able to ask a slightly different set of questions about what is making these people sick, what is keeping these people sick, are going to lead you to non-medical answers, and incorporating those non-clinical answers into a plan of care, I think is the biggest opportunity. And I think it's one that the industry is starting to get smarter about. And there's a lot of investment going into it, but I think that it's still very new.
Rich, how about for
Yeah, so a slightly different perspective because we have a different population. We have within PACE the sickest of the sick or the frailest of the frail. Same thing within the long-term care ACO that I worked on. So we knew who they were. That wasn't the issue. It wasn't identification. It was around how to pivot their management. Whereas before they became part of our care delivery model, they might have had, and they often did have, fragmented care, uncoordinated care, or the overall lack of care. And so pivoting toward a primary care model that's integrated and that's less dependent upon the ER is one of the challenges, and that requires a lot of trust building and frankly cultural change. Second, I alluded to during my introductory comments, which is a clinical challenge of not being disease focused, not falling into that trap, but really thinking of these folks as complex people who happen to have diseases and are on multiple medications that often aren't thought about together. So looking at that holistically and being concerned about polypharmacy, I mentioned that. Behavioral health is a huge issue in our population. 50% or more of them have a diagnosis of dementia. 85% roughly have a psychiatric or behavioral health diagnosis of some kind. So one can't forget that, and then the need to work with caregivers and proxies. And the last clinical challenge is introducing goals of care conversations and advanced care planning at the right time and on an ongoing basis, so that palliative care can be woven into care planning, and at the right time there can be an appropriate shift away from curative care when it's no longer likely to be helpful, when it's futile, and toward more comfort measures. I think I'd leave it at that.
Excellent. Marshall, Chris, I'd love to open it up to you here. Would you like to add comment? Marshall.
Sure. Well, I think you're hearing some themes of like, ultimately we have to tailor and individualize care to given populations, that all these patients are going to have multiple chronic conditions, oftentimes mental health issues, a variety of social challenges. And from an equity standpoint, typically like the first cut is, well, they have different identities, right? So looking at like race, for example, sexual orientation, gender identity. So the ability in data systems to be able to have that data. Right now, for example, race, ethnicity, language data, the gold standard is self-report of patients. A lot of systems don't have that right now, or something like sexual orientation, gender identity information, again, relatively new in terms of systems creating these informations. The deeper cut is this idea of intersectionality, that in ways it's too crude, general racial categories or like a general thing like sexual orientation, gender identity. So like with race ethnicity, ethnic subgroups can differ. So among Asians, for example, big differences between if you're an educated Chinese American, right, or if you come from Southeast Asian immigrant refugee history, right? We don't have that level of granularity. And then like just again, it's the mesh of then race ethnicity with class, for example, and all. So we need better data systems. Our general approach is that you can't have the one size fits all approach. That I think we've given like a different themes, but in any given like geographic area or population area or patient population, there's got to be then the more specific root cause analysis of what's driving the poor outcomes or the inequities in that particular population. There'll be some common themes, but some things which will vary across different sites and whatnot. And then the tailoring of the approaches to meet those needs. So for example, a thing that's come up, we talked about like good relationships, good communication. And oftentimes for racial, ethnic, minoritized populations, trust is an issue, right? So the way that is dealt with in terms of having like the trust, the longitudinal relationship is going to differ, right? So we need to have the granular data to be able to identify populations, do the root cause analysis, and then to tailor the solutions to be holistic, and again, another common theme, and then tailored for the particular individual patients' communities.
Oh, true. Chris, did you want to add?
Yeah, a couple of last thoughts on this question. So the first thing is I didn't want to run past one of the things that Rich stated about the population and PACE. And I think it's super important for PTAC as they're thinking about model design and which patient cohort. Part of what makes PACE effective and sustainable and well-matched is because it's the intersection of medical complexity with frailty. And what we found in our work is, as we're trying to identify patients who are persistently high cost and persistently need high cost programs, it is that intersection of medical complexity with frailty, functional impairment, because that indicates a group of patients who are unlikely to get better and continue to have high cost moments that we can ameliorate through high intensity care models. A couple of other challenges I think that are important for PTAC to consider is getting patients to say yes, frankly. I mean, many of us have the experience of building wonderful programs, and you only get 15% enrollment or engagement of the identified population. And so as PTAC is thinking about what models to support and how they can go about helping us, the patient and caregiver incentives to participate in high intensity care models are something that I think really need to be looked at. We see great engagement when we're able to offer some incentives to patients. I think other things that are challenges in this space, co-management versus primary management. And what I mean by that is we have in the literature, whether it's the VA home-based primary care, whether it's CMMI independence at home, whether it's the PACE program, those programs are not care coordination only programs. They are taking responsibility for the care being provided to patients. And they tend to be more successful than the programs that are co-management models where you have a patient on 18 medications and you're going to the PCP and saying, could you please maybe deprescribe a medication that I know is unsafe for the patient, versus if you're in the primary seat, you just deprescribe. So I think that is an important consideration as we're looking at care models. And then, related to that is this idea of care coordination versus actual care for patients. Care coordination in these complex environments with patients with such high needs, urgent care needs, et cetera, they don't need to be care coordinated. They need to have care either brought to them or someone who can provide care at the point of service and not be waiting for a call back from someone who's actually able to take the pen and prescribe. So I think those are important challenges with these populations and important insights to this team as they're thinking about which models to support. Thank you.
On Chris's point, because I think I forgot, I had it as a bullet, I think I forgot to cover, and Chris had it in his slides also. You remember Chris had a point about everyone says culture is important, and then all too often people don't incorporate culture. And I think Chris probably meant a variety of different things by culture. One of them may have been the latter point of that, we have these buzzwords like care coordination, but it sounds very basic, but it's basic caring for the patient, that we're trying to do. The point about equity that I wanted to point about on my slide was that it's the same thing that like a lot of mission statements like they're patient-centered or we care about equity and all, but when push comes to shove, equity is not prioritized and valued highly enough. And we found, for example, that when we have focused on the more technical things, so like the care delivery organization part of it or thinking about payment policy, that will only get you so far because to actually get the intra-organizational change you need to have it for it to actually happen, people have to truly believe that in this case, equity is truly important. And we're going to do whatever it takes across the whole organization to do the care delivery organization, to do the payment reforms to meet that goal. So this analogy is probably the more general point that Chris was making, that the same thing, that people have to truly care about the wellness of the overall population. And it's just not an efficiency thing that we're just going to do what we have to do to basically make the efficiency goal without truly doing the caring part. So I think like there's a tendency for us to fixate too much on like the technical parts of the conversation, which are important, but I hope we spend enough time on the remaining half an hour too, also on what does it mean regarding what we can do to encourage and incentivize this culture that goes for the patient and community health and the equitable outcomes.
I also think a lot when we speak about medical frailty or physical frailty, but also the constellation of social frailty. So I see that a lot in my work, the crossover between trauma, poverty, interpersonal violence, behavioral health, the constellation of things that make for an equal complexity we have so much opportunity to deepen how we understand and address that. Chinny, I see you have your card raised. Please go ahead.
First of all, thank you to all four of you for your excellent presentations and thoughts. So my question is more around the pathway to taking on global risk for a lot of organizations. As we know, there's two sets of worlds. One is how do we get people to take on more risk and get to more value-based care principles? And the other side of it are organizations that have already done that and can allocate resources to that. So I think those are two different conversations. What I'd like to ask all of you, starting with Erik, Drs. Feifer, Smith, and Marshall, is as you think about a pathway to risk, and I've heard all of you speak about coordinated care and care teams being, important. What are things about the payment mechanisms today on that pathway to risk that would help incentivize better the care teams that you're speaking about? What are we not paying for that we should? And then I'd like you to also think about the patient side of it, right? I've heard a couple times we need to get patients to say yes. So what are things that from a payment mechanism could potentially help patients say yes more than 15% of the time?
Did you want me to kick that off, Lauren?
Sure.
Okay. It's a big question. There's a big answer. I'll try to offer part of that big answer. There are a lot of models that we should be thinking about incorporating into other parts of the Medicare program. And I think a lot about the annual wellness visit in Medicare Advantage. That is a metric that people pay attention to. They organize incentives around, they organize activities around, and it generally drives pretty good adherence when a provider group is taking risk in Medicare Advantage. What are the other visits that need to be paid for or emphasized or stressed in the delivery of fee-for-service medicine in an ACO or in other risk-bearing models that prompt a different set of questions? And I think part of this is building a little bit on what Marshall was saying earlier. I think the medical, I'm not a doctor, okay, so I apologize in advance, but I think the medical profession isn't used to asking the questions that need to be asked. And I'll give you an example. I think, Chinny, you probably heard me use this example before. We had a health system, safety net health system, looking to take risk on duals and Medicaid eligible individuals. And they identified something that they called the $20 problem. That is, after an individual was discharged from the hospital, they were discharged with two things that they needed to do. One was to fill a prescription, and the second was to check back in with their primary care doc within 10 days. This was a transportation desert that the safety net hospital is serving. So there wasn't a lot of bus service. There wasn't a lot of rail service. So that individual is going to have to pay for 2 cabs or 2 Uber rides. And they couldn't afford it. These are Medicaid individuals. They could do the drug or they could do the check-in with the physician, but they couldn't do both. As a risk bearer, the questions that they started to ask at the point of discharge was, do you need a ride? Do you need a ride for one of these visits? And that's the kind of question that isn't always asked at the point of discharge that will drive activity down the line. MA plans have increasingly adapted non-emergency transportation services as part of their supplemental benefits. It provides a huge benefit, particularly in rural areas, for individuals. But I don't believe it's on the Medicare fee schedule. Should we be paying for that? Should we be encouraging folks to schedule the follow-up visit, paying people to schedule the ride to the pharmacy? I think there are a lot of tactical things that start to take in the contextual situation that the patients find themselves in And I don't mean to be an apologist for Medicare Advantage, but I think Medicare Advantage plans have started to think about what is the next step that we should be asking for in order to better manage the risk that we're taking on.
If I could build on Erik's comments, I think your comments about what should Medicare be paying for on this path toward total cost models, that's an important one, paying for transportation. And what that reminds me of is the shift over the last few years, and this has been very favorable, toward paying for unlimited, essentially, advanced care planning conversations. That's really important. Especially for this population. That was a very important and meaningful move, and it's much appreciated. On the other hand, there have been some attempts to improve care through payment of services that maybe haven't gone exactly as planned, or one could say that they're a little more controversial. And there I'm thinking about Chris's comments about the difference between coordination of care and care, right? And what we really want is the primary care hub to deliver care and the primary care hub to coordinate care. And one can really question the value of having care coordination occur outside of that hub. And I think well-intentioned payments for care coordination, might have led to more fragmentation rather than more integration at the primary care level. I don't know if you'd agree with that, Chris, but your comments reminded me of that.
I would totally agree. I think one of the big challenges to the question of getting patients to say yes is they're bombarded with people calling them to try and coordinate their care, coordinate their transition, help make sure that their social determinants are uncovered. Each individual program had a good reason for coming together. Each individual caller has a good mandate that they're trying to solve for. And so I think if we want to get higher engagement rates, we need to be a little bit more clear on who is responsible for the patient, and then as importantly, who is no longer responsible for the patient and should cease and desist activities that confuse patients and families. I think we should think about paying patients to participate in some of our really successful programs. $25 a month to answer the phone call when your care navigator is calling might actually be really helpful to keeping patients persistently engaged in programs over time. We can talk about trust, and we need really high quality clinicians to build trust, but $25 a month might actually help things. Some other things that we need to do to improve the performance of provider organizations, health systems, their willingness to take full risk. Things like concurrent risk adjustment would be really helpful. I think we need to move out of demonstrations and into programs that are now law, and therefore we can business plan for 10 years as opposed to 2 years. When I was in the health system side, and I would go to our CFO and say, I would really like to put us into this risk-based environment, we would look through all the requirements and the changes that were going to happen. And they'd say, okay, so after 48 months, you're going to change the baseline. So if I'm performing really well over the first 48 months, what you're guaranteeing me is I'm going to put in expensive infrastructure, and then you're going to take away the revenue in years 3, 4, and 5. If we don't fix those problems, you will not get more providers into this space because they're reasonably saying, I'm living on a 1% to 2% margin. I can't tolerate the risk of going into years 3, 4, and 5 with this expensive infrastructure that's required to manage total cost of care. I know these are things that have been said before and that you've heard, but we still 15, 20 years into population health haven't solved them completely.
So I'll answer the two questions from the perspective of the safety net. So I do a lot of work with federally qualified health centers and safety net hospitals, institutions. And so the concern is similarly, as Chris said, very small margins. And so really at risk if things don't pan out. Oftentimes not the data infrastructure and analytic infrastructure to be able to initially do well strategically. And this is one of the concerns with some of the existing programs like the hospital readmission program, which found that like the safety net was often particularly harmed. Probably one of the reasons is because of not having the infrastructure to do well regarding like the quality improvement programs and all. And so it means then that, first that having like some of the upfront infrastructure money or some of the per member per month or capitated money upfront, along with coaching to help with that infrastructure. So like the IT and the analytics and whatnot, and or partnerships with other parts of then the network or system that would be able to help with that particular skill set that may not be as common amongst some of the safety net. Also, the idea then, as in many other programs, of the ramp up. So like pay for reporting, upside risk, then upside and downside risk. So needs to have like sort of a gentle glide path, and in particular, the part about the technical assistance and coaching part, I don't think we do that nearly enough. Assuming that just money will do it and all, or the overall incentive, having some type of coaching and TA support available, some plan for that, I think would be helpful also. Your second part of the question about like patients, I'll actually answer maybe even. Well, I think maybe a more vital part of it is that we talk about involvement of patient communities. Oftentimes, again, it's lip service. And if we really want to have the culture change, if we really want to have the North Star on patient and community health, actually involving patients, communities in the governance structure, power sharing is the way to go. With our most recent version of our National Advisory Committee for our Robert Johnson Foundation program, 3 of our current National Advisory Committee members are current and former Medicaid beneficiaries with advocacy experience. It's just changed the total dynamic of the discussions and all with the different teams and all. So again, going beyond like lip service to, if we want to have meaningful change and really truly put the patient communities first and have the focus stay on that as opposed to other non-patient community health goals, power sharing communities is important.
I do want to build on one thing that Chris said earlier about paying patients to participate, because I think that's a really astute observation. I think the other thing is we need to figure out a way to monetize and incentivize the participation of caregivers and families. They become incredibly important parts of the care team, particularly with this population, and especially as we move into complex and frail. And I don't think we've unlocked that door yet. I think, and I don't have a recommendation, but I think it is an area worthy of research and investigation about how do we put money on the barrel in order to get providers to engage with families and for families to engage with the provider team.
Erik, I'm glad you added that. That reminds me of paid caregiver programs. We have that going in a few states, and it's important for 2 reasons. One is the reason you stated, absolutely 100% agree. It's also important because we have a huge talent shortage among caregivers that we might want to hire and we can't find. And so it helps us on both sides.
Also a really interesting equity issue. So Angelo, please go ahead.
Yeah, thank you, Lauren. So I've heard some things during this conversation that over the last year or more, as we've interviewed a lot of subject matter experts, the 2 themes that keep coming up is the importance of team-based care and the importance of non-telephonic, personal outreaches to patients and how often those occur. And I've heard you all reiterate that somewhat in this, but also acknowledge that even a team-based approach can get fragmented and actually decrease outcomes as opposed to improve outcomes. So I'm curious, how do you all actually define what team-based care? What's team-based care mean to you all? And what things do you put in place to make sure it doesn't become fragmented like I've heard described? So I'd like to start out with Richard on that.
Well, thanks. And if I could first just comment or clarify something you said about lack of telephonic. I would argue that telephonic can be just fine depending upon the situation if it's coming from the primary care team. I think the problem that I heard earlier from Chris, I don't want to put words in your mouth, Chris, is this fragmented telephonic outreach coming from a variety of organizations that have nothing to do with the care delivery team. That's the problem. But to have frequent touch points, whether they be in person or video or telephonic, whether they're in the center or office or in the home, coming from the broadly defined primary care team, that's great. And we should encourage that as much as possible. So I think that's the most important point that I want to make on that. Others?
How would you define team-based care then?
Yeah. Oh, sorry. Team-based care. Look, PACE is defined for us. PACE was defined by the enabling legislation decades ago, and it involves 11 members of the interdisciplinary team. But I don't think that's really what you're getting at. What you're getting at is what's important for team-based care, and I could define it kind of conceptually as well. That depends on what each patient needs, right? Someone who has a complex, let's say, cardiovascular episode, you want that cardiologist or someone advising on that to be in some manner integrated with the team. But I don't think that's what you're asking either. I think more commonly for our population, again, the frailest of the frail, it's very important for the team to involve, in all cases, therapy, PT and OT. It always comes up. These are folks, whether they have acute or chronic mobility issues or functional issues, they're part of the team. Social work is always part of the team. Primary care and nursing are always part of the team. Then you get beyond that, it depends upon individual characteristics. But the more we can have the payment model provide the right incentives for the team to coalesce and deliver services together versus in a fragmented way, the better.
Marshall, please go ahead.
Yeah, I was going to build upon Rich's comments, and I agree with everything Rich said. I was reviewing the National Academy's primary care report recently, actually last night in prep, and you think about it, like a lot of principles of primary care are the ones that I think apply the answer that there's someone in charge that is ultimately responsible. They have a trusting relationship with that patient and family. There is some type of longitudinal relationship. There are a variety of different specialties or services, physical therapy or whatnot that may be involved. Ideally, they are seen as part of the integral whole. So that's the problem with some of the telephonic interventions. If it's like some outside group that is not really sort of viewed as coordinated with the team or that has that trust and relationship with the patient. Otherwise, there could be models that at a minimum, then that primary team is truly coordinating and orchestrating. But I think a lot of it devolves down to like those basic principles of primary care, which can be applied then to the definition of team-based care. The trusting, the relationship part, the communication part, being I think two of the critical ones, which again are the things which just tend not to be valued either culturally or financially in our systems.
Chris, did you want to comment?
Yeah, just a couple other thoughts to add on to Marshall and Rich about what is the interdisciplinary team. I think one of the mistakes we sometimes make in this space is, and I'm going to use an example. I'm not picking on pharmacists. So if there are pharmacists listening in, I love pharmacists, but like there's some good data that you can have a pharmacist helping in a primary care environment, right? But in most primary care practices, the percentage of patients who have severe polypharmacy that is impacting patient outcomes is less than 5%, right? And so, but then you have some of these complex programs where every patient has polypharmacy, or 20% of the patients expire each year on service. And so within those programs, your physicians or your APCs, they should be able to have some abilities in primary palliative care, for example, and some abilities in managing medication complexity, such that you shouldn't need necessarily to keep increasing the interdisciplinary team to have a pharmacist, to have a palliative care physician. Like the team should be a little bit tighter. It should be a doctor, nurse practitioner, nurse social worker with some physical therapy. And we ought to be careful not to continue to proliferate role types when a lot of that work should be done by the primary team.
That's so interesting. And I think I'm just going to add my own additional question about that. So you've talked about the importance of anticipatory management or proactive identification. And I think it's very interesting to think about what discipline or what training creates that ability and sustains that ability. No, I'm going to go next to Walter, and then Josh will be next.
I just wanted to start by thanking our panelists for just such a rich discussion. I'm learning so much. I want to say one of the underlying theses for this two-day meeting is that for this particular population of patients we're talking about, better care management, more intensive primary care can actually both improve quality and decrease costs compared to an unmanaged population. And so one of the reasons we asked each of you to speak in this panel is because you have experience in running real-world programs that have achieved these kind of outcomes. I'd just like our panelists to paint a picture of what is possible for from both quality and financial cost perspective in a tightly managed program compared to unmanaged fee-for-service. The more specific, the better. So if you can give us kind of just paint a picture of the opportunity out there that Medicare can look at and try to perhaps emulate.
Well, I might kick it off, Walter, since there weren't any other takers yet. But what I think of is a recent experience in my own organization, where the financial model created an enormous incentive to invest in care delivery, and that's really what we're talking about here: to invest in care improvement. How do you create an enormous, compelling incentive to do that? And we had that here in our population, again, PACE, which is very much a frail, often end-of-life population that largely lives independently. And we were seeing very high costs that were attributable to end-of-life experience and direct costs related to hospice. And as you know, hospice is fully carved into the capitation at PACE, whereas in the past it has not been fully carved into other payment models, but it is in PACE. And we asked the question, are people receiving the right experience through that? And we are very passionate about palliative and comfort care, but in many cases, they were not receiving the right experience. It turned out that it was more fragmented than it was integrated. And our whole model is around integrated care. So that created an incentive for us to do it better internally. And so we're investing an enormous amount, given our scale, in palliative care training, in hiring staff, 24/7, 365, that we can go into the home, we can bring people into our centers, and we can provide what people need internally, and having that be fully part of our care process. I think it's a good story. It's a good case study of how to create the right incentives and then let the care delivery system figure it out on their own, because it's compelling.
It's a really big question. What does it look like? You guys are asking big questions today. I think a lot of what Rich just said, I'm gonna steal. From the standpoint of the committee, I think about four big things that constitute what you're trying to get at. One is putting programs in place that reward scale. I think from an actuarial standpoint, from an investment standpoint, from an amortization standpoint, you want to be able to scale across geographies and aggregate as many populations as you can. The second is, this is probably a bell that's been rung 1,000 times in the last 30 years, but reward primary care and try to drive primary care attribution that way. The third element, I think, getting back to some of the investments in technology that I've heard other people mention, and I wholeheartedly agree with, is providing clear visibility into the populations that are attributed or assigned and what their needs are going to look like over the course of the next 12 to 18 months. And I think the analytics exist to do that. And then the fourth element I think that the committee should consider, and I think you already are, is aligning incentives in Medicare and Medicaid. I think that gets to the scale question that I mentioned up front. When you think about large physician groups, integrated delivery networks, they are serving a lot of different types of payers. And it's hard to optimize for the Medicare frail population when it represents less than 20% of your patient groups. There are going to be investments that are sort of bespoke to that population. Again, back to my comments earlier, that's where the money is. But you want those investments, I think, that you're asking for health systems and physician groups to make to amortize over multiple programs, whether that's MA, PACE, Medicaid managed care, ACOs. It's got to be aligned. And I think that is happening slowly. We're seeing that with Reach and Ahead. I think that's good, but more needs to be done.
So I'm going to build upon Erik and Rich's comments and again, take the equity perspective. And you remember Erik's slides, he had like the risk stratification. That was the first point, Erik. So it's all a spectrum, of course. And then, I'm on the most severely ill and all, then you have your highest percentage of people where you have that cost savings opportunity. I think like in the equity field, there's been a concern that sort of a dual standard regarding the overall discussion, so that sort of a strict cost savings perspective applied to marginalized populations more so than other populations. And so, as I think as Rich was saying in his comments, as you go lower in that pyramid regarding like the overall risk, severity of risk and all, you're going to have then a fair amount of care that's not necessarily going to be cost savings, but it's going to probably be high value. I mean, Rich mentioned like the patient experience for end of life care, or just like the overall disease outcomes, condition outcomes, and overall health then for the marginalized populations. So I know that part of the discussion that you have as a committee is like, well, the cost savings component of the discussion. But I think within your wider role, just sort of put on the table of just being careful regarding like not having the double standard for marginalized populations and not undercounting the numerator part of value and of the value equation, especially for marginalized populations and policy.
Chris, did you want to add anything?
No, I think we can keep moving. I think everybody's comments covered my comments.
Sounds great. Josh, please go ahead.
Great. Well, thanks everybody for really thoughtful presentations and the discussion so far. I know that Erik mentioned kind of big questions. I'm going to try to give a big context, but land a small question perhaps for the group. One thing that came up just a little bit ago that struck me is this question about care versus coordination of care. And it's something that I know our group and many others have been thinking about. No doubt all of you have been thinking about it as well. And, often I think the conversation's framed as we don't have enough care coordination. Fragmentation comes from not enough of this. And I've heard a few of you allude to the fact that we might have too much, that there may be double, triple duplication, maybe some of that. So I'm curious if we take both sides of the issue, and I'll focus more on the latter because of that. If you had Penn to design the model today, what is the one thing you would do to fix that issue? I heard a term cease and desist. That's not exactly a friendly give a hug type of action. There's some firmness behind that. So what would that thing very practically be?
Well, I think I'd like to start with a short answer, which is to provide every incentive for the primary care provider and the primary care system itself to be responsible for care coordination and to be responsible for any failures of care coordination, whether that's through payment model or other measures. Because if one does that right, and I believe in PACE, it's structurally designed that way, but you want to extend that model to other systems. If done right, then the primary care system will figure it out. They will care coordinate.
Josh, I'll answer your question in a slightly different direction. So I think we have to be super clear on what it is that we're trying to accomplish. So there's oodles of literature and data that care coordination can improve certain things. I mean, it certainly can improve patient experience. There's some evidence that it can improve caregiver burden or burnout, but But if you're looking for total cost of care amelioration, care coordination is like the wrong tool, right? If it is a standalone service. And so I think if we are really looking for total cost of care improvements, there has to be a interdisciplinary team, whether it's the primary care provider or some disruptor where the patient is removed from a failed primary care relationship and moved into a new one. But some entity has to be responsible for being able to provide longitudinal care, urgent care, and probably, if we're talking about this population, palliative, a mixture of palliative, social determinants, and behavioral health, depending upon what the patient needs. But I think part of why care coordination programs fail is in almost every care coordination, one of the key boxes that you have to check is, does that patient have a follow-up appointment with their primary care provider? Well, there's like a big logic fallacy there, right? Part of the reason why that patient is failing is because they are in a care environment that is not meeting their needs. And all our care coordination programs can do is try and keep pushing them back into that care environment. And so if we don't address the fact that part of why patients are failing and therefore rising up in the claims is because their current provider isn't structured to meet their needs, we won't make the progress that we need to make. It's a bit controversial, but I think it is part of why we see care coordination programs fail. They just keep pushing patients back into systems that aren't responsive to their needs and wonder why they're still in the emergency room.
So Josh, I love your question and how you started big picture and then came down to a focused question. And I'll give you sort of a qualitative answer in response. So I mentioned, like, I'm on the general medicine service right now, and most of our patients fit this category. Two in particular have very involved family members. And in some ways, the family member has played the care coordination role across different systems of care: inpatient, outpatient, clinic, specialty services, rehab facilities, et cetera. And so, I mean, to me, the thought experiment is, well, how would the system be set up so that it doesn't have to be that person that's tying it all together? I mean, who would be the person or team or structure such that this is sort of assembled together so it's an easier discussion for that patient and their caregiver, advocate, and all. Harder when it's not an integrated system, hard even with an integrated system. But I think partly gets back to the issue of, like, sure, there probably can be like incentives and all that can help encourage this. But it gets back to the cultural point too, that the system has to prioritize that this is something we're going to do, because this is a heavy lift implementation wise. Again, finances will help, but it has to be cultural too, so they go hand in hand. But that's a thought experiment I would do of like what would be necessary so that the patient advocate doesn't have to do all that time together on their own.
Erik, did you want to comment as well?
No, I think my comments have been well covered, more articulately by the other panelists.
Excellent. Larry, I'm going to turn it to you.
Thank you. And thanks to the panel. This has been a very stimulating discussion. I've been hanging on by my threads with this conversation. I'm going to bring out a couple of comments that I jotted down. Erik made the comment that we need to bridge the gap between providers and patients. Chris spent some time talking about reactive versus proactive care. We just had a very in-depth discussion about, with the last question, about how we would get primary cares to actually implement this. I don't know what primary cares you're seeing in your organizations, but I'm seeing primary care doctors seeing 5 patients an hour. And they're hanging on for dear life too, especially in these very seriously ill patients. And they wind up bouncing specialist to specialist to specialist, who are all paid fee for service and aren't in any kind of a risk arrangement. And we're gonna have our meeting in September talking about the glide path that we have to go on to accomplish value-based care. I don't know that I've heard from the four of you concrete items as to how we glide these primary care doctors into the model you want them to be on. The only way I can see it is if the compensation model drastically changes. Because they don't have the time, they don't have the staff, they don't have the wherewithal to handle these complex patients under our current model.
So Larry, I'll start. I think there are practical things that we can do. If the question is, how do we activate our primary care workforce? So the first is we've got to offer prospective payments to those provider groups to be able to participate in these, and it's got to be real money so that they don't have to see 5 to 6 patients an hour, right? We have to, and then we have to protect them from the downside of some of the early years in the transition. And that's what you see right now in the private equity venture space is everybody's trying to grab these primary care practices by providing protection from downside risk in the first several years while you get your capabilities up to speed. So we can continue to allow that to be, a something that's done in the for-profit space, or we can figure out how to do that in some of these demonstrations, because the for-profit space takes some of that money out of the system for profit. So I think we need to do that, and I think we also need to we need to be super clear about what we expect to be invested in, and I think we have enough evidence over the last decade to say, like, if you're going to take risk on highly complex patients, you have to invest in urgent care capabilities, same-day urgent visits within your practice. If you can't do that, patients won't come to you when they're having an exacerbation. So how are you taking the seed money, and whether it's creating space within your schedule to see patients if they call, like, what's the measurement that we can do for inbound clinical calls? What percentage of them get a same-day appointment, for example? And then I think, you've heard it several times, like, how do we incentivize high quality palliative care, where probably the terminal measure of percentage of patients who expire on hospice is really the right measure, because if you're holding folks accountable to that, you have to put a lot of activities in place rather than just enough documentation to get paid the advanced care planning code within the Medicare fee-for-service. So I think there are practical things that we can do to get our primary care workforce to be more successful in this space. I'll leave it to the rest of the group.
Erik, I think you had your hand up first.
Sure. Just to build on those comments, this is kind of a Cortez burn the boats kind of question, I think. I think a lot of the incentives that have been put in place in front of primary care docs just are insufficient. And I've talked to a lot of primary care physicians who sort of surprisingly to me have said, can you move me to risk as fast as possible? That's not a conversation I was having 5 years ago. But when you dig deep into that, why they're asking for that, it's just pay me capitated payment or something up front to smooth my cash flow and give me the freedom to call the patients I know I need to call because I know they need to be seen and I need to intervene. Because right now in a fee-for-service world, I'm just dialing for dollars and I'm filling my slate of appointments as much as possible with whoever answers the phone. Putting in place a care coordination fee, not a bad thing. Putting in place quality payments, not a bad thing. But I think we really need to go much faster towards something that really makes a tectonic shift in the economics of primary care to make it worth their while to make that. And I think in addition to that, and this gets a little bit to what Chris was describing, we need to have a readiness template before we do that with those physicians. In order to participate in this type of Medicare payment program, you need to be able to demonstrate that you have these types of capabilities in place to manage that risk. With that in mind, I think you would see a lot of willingness of primary care to move into something that looks like capitation or PMPM. But the incremental adjustments that we're making to the fee schedule in order to encourage this, it's not going to work.
Yeah,
And Marshall?
amen, Larry. Thank you for that question, which I think really is one of the ones that gets at the root of the problem. You remember we talked earlier on about like the underlying systemic structural problems. I think you hit your head on the nail with what maybe the fundamental problem is primary care, or more generally, the types of services and functions that are represented by primary care. When we're talking things like the care coordination, the good communication, the trust, the holistic view, addressing the social, integrating the medical, the mental, substance abuse, and whatnot. I mentioned like last night I read like the chapter I read in the National Academy of Primary Care report was the payment chapter, which I would recommend that maybe that the committee and staff take a look at again. And the story is that like there's the first National Academy of Primary Care report was 15, 20 years ago. And in some ways, like not much changed. Much of the recognitions were not implemented. So the charge for this most recent report, which came out a couple of years ago, was implementing. So that's the title, implementing the high quality primary care report, of which a big part of it is going to be then like the payment and then other regulatory mechanisms. And then this particular payment chapter, they go through like 4 different options, ranging from like pure fee for service to hybrid models of fee for service and capitation, pure types of global payment models. And then the 4th one is like, if you actually say a priori, we're going to devote X% of the healthcare budget to primary care. And their review, at least at that time, was that like, this is the nascent area, like so CMI has had a variety of different demos and also a few demos, but there's clearly not sort of a clear answer here. I think like Erik talked about some of the principles that these programs have tried to do, and so there are nuggets there. But that's the challenge really of the committee for this topic of, given those goals of, these structural goals of primary care prevention, care coordination, communication, trust, social needs, integrating medical, social, substance abuse, how can that be done both in terms of the incentives and payment and then the culture? So I would suggest taking a look at that chapter in that report just as a refresher regarding some of these existing data and whatnot.
Thank you, Marshall. And Rich, please go ahead.
Thanks. I had 2 reactions to my colleagues that I thought I'd add to some things that they said. The first, Erik, you said around primary care incentives, give them the freedom to do what they need to do. And I think there's something incredibly valuable there. You said it really well. It's the freedom, it's the air cover, it's the financial incentives, and let them figure it out. And it may be the individual primary care provider, or it may be the leadership of that primary care delivery system that has an even more compelling incentive to get their primary care providers to figure it out, or to bring additional resources to bear at the primary care level. That is the essence of what's necessary here. It doesn't solve for workforce shortage issues, which is a whole separate category we could discuss another time. But where we have the right staff, that's how you get from the 5 or more visits an hour to 2 or 1 visit an hour, because that hour-long visit is going to avoid a hospitalization or an emergency visit that pays for itself. That's how you get that to happen. The second thing I wanted to react to very quickly is Chris's comment about hospice. And it begs the question, what are the right performance metrics? Everything isn't about financial incentives and payment models, right? But there's also performance measures, whether quality or operational performance. And Chris, you mentioned a common metric, which I've used in the past, which is the % of a population that ultimately dies on hospice. I've gotten away from that in several organizations because for us, that's created the wrong incentive. And what we've implemented instead, which we find very helpful, is the % of the population that had a hospitalization in the last month of life. Of course, it's never going to be 0. But if you use that as your goal, then you're going to put in place whatever is necessary to proactively identify people with a high short-term mortality risk, to put in place the right incentives for primary care, to have advanced care planning conversations and goals of care conversations, and to think about introducing palliative care at the right time, and to put in place all the resources you need so that when the prognosis is in fact dire and curative care is likely to be more harmful than helpful, then there's a pivot and people tend to not be hospitalized as much. So that to me is a golden metric that hasn't been used enough in healthcare.
This has been incredibly rich dialogue. Each of you have a very valuable perspective, and I feel like we're just getting started, but we only have about 3 more minutes left. So I wanted to give you each a chance to add any additional comments that we didn't get to that you think would be helpful for the committee to hear. And Erik, you came off first, so I'm going to go to you first.
That we didn't get to today. I think we need to spend a lot of time thinking about how do we integrate specialty care into these models. I don't have an answer to that. I'm fascinated to see what the committee actually delves into on that. But I think, particularly with this population, addressing some of the specialties and getting them involved and having some skin in the game is incredibly important.
And Rich, you had your hand up next.
Well, I had my hand up as a legacy from the last comment, but since I'm unmuted, very quickly, I heard as we were joining before, maybe it was during the Q&A after Walter's initial presentation, the difference between identifying people based upon diagnoses versus characteristics. Just one of the committee members mentioned that, and I wrote it down. That's precious for this population, and so I'd like to build on that. What characteristics? Characteristics are frailty. Characteristics like recurrent falls. Characteristics like using the ER on a recurring basis for non-emergent needs. That's a behavioral characteristic. That's how we identify people for outreach. And characteristics like mortality risk, so much more important than disease focus. So I thought I'd give some more granularity to that. And then, of course, what we need to do on the delivery side, and this has been said a few times, is to make sure that we are providing the 24/7 access for this population so that they trust that we're here for them and that they're not using more expensive and lower value sites of care. So I'll leave it at that. Thank you.
Thanks. Marshall, Chris?
Yeah, so in the appendix to my slides, I have a recent NEJM piece that Alicia Fernandez and I wrote that came out maybe a month ago about health equity. We talked about like 3 different areas, 2 of which we talked a lot about during the past hour: care reorganization and payment. The third, and one that I would highly encourage the community to think more about how that can be aligned then with your payment policies and whatnot, is this category of values and governance. Because ultimately, all this depends upon everyone truly valuing these principles of care management and things like Erik said, like it's truly managing holistically the patient and communities with these complex patients. But all too often, really, the systems and incentives aren't aligned to really care about patient and community health as really the North Star. So I would sort of end with that refer to the NEJM paper that Alicia and I wrote, and then thinking about how can that be integrated through the values and governance piece with what we've talked about regarding payment and care transformation.
Marshall, please take us home.
Yeah, so the last advice I guess I have for the committee is I haven't looked at all the different groups that you're bringing in today, but if you don't have a CFO panel, then you're going to miss out on one of the key voices in figuring out how to get these programs to be adopted more widely and scaled more substantially. They hold the key to yes or no, are we going down this path? And I think that there continues to be, as I've mentioned a couple times, a lot of challenges with the way in which many of these demonstrations are financially structured. And if you heard those voices, I think you would understand even greater depth how things need to be constructed going forward.
It's a great point when we think about interdisciplinary teams. I think they're part of it. Really important to think about. So we've covered a lot of ground today. We want to thank all 4 of you. We know your time is very valuable, and we really appreciate all of your perspectives. You're welcome to stay and listen to as much of the meeting as you can over the next 2 days. At this time, we have a break until 1 p.m. Eastern. Please join us then. We have a great lineup of guests for our roundtable panel discussion on provider perspectives on improving outcomes for patients with complex chronic conditions or serious illnesses in total cost of care models. We'll see you back at 1 p.m. Eastern.
Produced by the U.S. Department of Health and Human Services.